بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله وعلى آله وصحبه أجمعين. ابتداء بحب أشكر الدكتور مازن دوماني والتيم تاع الدنتستري أونلاين على الدعوة الكريمة للمشاركة في المؤتمر العاشر. أنا الدكتور طاهر العمري من جامعة العلوم والتكنولوجيا، أستاذ مشارك وكونسلتنت اندودونتست. المحاضرة اليوم حتكون عن CBCT, how to read and how to assess the CBCT and why to use it. ابتداء محاضرتنا تعتمد على guidelines for the American Endodontic Association. We start with how to assess our endodontic case. لما تجيني endodontic case, how I will assess the endodontic case. We should start with clinical examination. احنا اي كيس هتجينا هنعمل clinical examination, then we go for the diagnostic imaging. Diagnostic imaging, usually we use the two-dimensional X-ray, the conventional X-ray, like the one on the top right side. الآن when we assess such an X-ray, we notice that there is a resorption in the distal root. So what is the level of the resorption, where the tooth will end, where other parameters might affect us, if there's any fracture in the root. All this information we can obtain from the CBCT. For the uses of the CBCTs, we start with the endodontic diagnosis and detection of periapical lesion. When there is a contradictory result or contradictory and non-specific signs when patient بيشكي من pain, usually we could take a CBCT to verify the presence of periapical lesion. في الحالات اللي المولرز زي هيك ممكن الفيتاليتي تيستينج تكون inconclusive، ما تعطيني ريزلت دقيقة، يكون جزء من السن فايتال ستيل، فبعطيني ريزلت او بعطيني ريسبونس على الكول تيست او على الاي بي تي. وبهيك حاله taking the CBCT will help me to detect البريبيكال ليجن. في multiple studies فرجت انه chances to detect البريبيكال lesion using the CBCT is much higher than the periapical X-ray. احنا عندنا تقريبا 50% of the cases we can see the lesion on the CBCT, and less than 20% of the cases we can see the lesion on the conventional X-ray. طيب, what else we can use for to assess the anatomy before the treatment? فأنا إذا عندي case I'm going to do root canal treatment and I'm not sure of the presence of extra anatomy, extra root, or unusual anatomy, one of the indication is to take a CBCT to verify anatomy in such a cases. برضو في surgical and non-surgical root canal retreatment, usually we can take CBCT to verify the presence of the MB2. Example, the case on the right, الكيس هاي تحولت بعد ما فتحوا access لل7, although it was vital, it was just normal, and the patient has complained of pain. 6 has a periapical lesion confined to the mesial root, which is most probably coincide with the presence of missed canal and infection in the sinus. That's why it wasn't much clear for the dentist that the 6 was the causing of the pain. For the MB2 per se, chances that can be seen on the, or can be expected on the X-ray, conventional X-ray, was around 40%. However, using the CBCT, we could go up to 80% in accurate findings of the CBCT, of the MB2. Another use of the CBCT is to assess the surgical site, where we are planning a surgical endodontics. In such cases, we need to assess the anatomical landmarks, the vital structures around, and the spatial relation to them, the lesion size, the reason of the failure, and if there is any other evident signs of vertebral fracture or something else. We can use it as well to assess an inflammatory resorptive defects like external and internal root resorption. Also, it can help us to determine the prognosis of such treatment. Also, in trauma cases, we can use it for prognosis. We come to the trauma, like in other use is also using it for the cracked tooth syndrome and the vertical fracture. النقطة إنه CBCT is not accurate in detecting a vertical fracture and it's not conclusive. Usually we cannot see the vertical fracture and the cracks on the CBCT, but we might see signs of vertical fracture, like pattern of bone resorption or something like that. Sensitivity to CBCT to detect vertical fracture was high. And low for the PAs. However, the presence of the metal post and GB, Getaperca, might affect the findings. So we cannot depend really on the CBCT to detect a vertical fracture. Still, the best scenario or the best diagnostic tool is the dye examination and the surgical exploration. Trauma cases also can be assessed on the CBCT, and we use it to detect the pattern of trauma and fragments and what treatment we should do, as well as the prognosis of the case and if other options are favorable. For example, the horizontal root fracture, is it the extraction or the splinting of the teeth or other treatments? So vertical fracture usually can be assessed, or horizontal root fracture can be assessed easily with the CBCT. الآن for the follow-up X-rays احنا بنشوف انه في كثير زملاء بيفرجونا صور CBCT ل follow up for no reason. Guidelines indicate انه احنا we only allowed to take normal periapical X-ray for the follow-ups, and if we need to assess the follow-ups for the lesion size or something like that, we can go for limited field of view CBCT to decrease the dose of the X-ray. Other modalities that we might hear in the future will help us in visualizing the anatomy and the structures. The ultrasound is a new device, high frequency ultrasound for the assessment of peri-implant. It has been published, and this is a new device. They use it for bone assessment and the assessment of the implant and implant surrounding structure. It can also help to assess a soft tissue around the implant. We can use it as well for assessing the soft tissue and the periapical lesion, for example. Another tool that might gain interest in the future, MRI. There's a special MRI for dentistry, and this MRI can be used easily to detect resorptive defect, anatomy, cracks and things like that. إذا قارنا الام ار اي بالسي بي سي تي، الام ار اي في الصورة العلوية تشوفوا الفرق بين السي بي سي تي والام ار اي بالريزوليوشن بالديتكشن. الام ار اي as well able to detect the presence of lateral canal, resorptive defect أو الاناتومي itself. فالفيوتشر حيحمل لنا new devices that might be impacting our field زي الام ار اي زي الالتراساوند. it will just take time like the CBCT to be developed further وتكون cheaper واكسسبل لمعظم الزملاء. الان let's go with our cases. انا حاعرض 3 cases ونحكي فيهم how to read the CBCT. الفيرست كيس is تقريبا 48 years old patient. مريضة تحولت لي من طبيبة أسنان بتكون بنتها زميلتنا وطالبتنا. حولت الحالة due to pain, severe pain. البيشنت بتشكي من بين في المنطقة left side of the face, upper and lower, and she point out إنه البين increased في lower 7 after the root canal treatment done by a general dentist. الآن ال OBG examination was not conclusive, بس احنا كنا شاعرين إنه there's something on the upper 4. Clinical examination was also non-conclusive. I could not see any caries on the occlusal surface. Taking periapical X-ray shows presence of periapical lesion on the upper 4 with calcified canal and almost sound occlusal surface with deep caries cervically. Lower 7, we have huge access with possibility of gouging. Something is here, might be a missed canal, might be a perforation, I'm not sure, and acceptable level of root canal treatment. الآن we refer the patient for the CBCT and we took the CBCT. هنروح الآن نشوف كيف CBCT can be read. CBCT بتجينا بالوضع الحالي. أول ما نفتح بنروح للكيرف سلايسز وبنقدر نعمل alignment الكيرسر على أو الماوس على التوث اللي بدنا نشوفه ونشوف coronal section. Okay. لكن احنا ما بنقدر نشوف كل الاناتوميز. we cannot really assess the axial section, we cannot assess sagittal as well. بنروح على oblique slices. we can move 3 axes ونشوف all the 3 levels. بالتالي احنا ممكن نروح للاناتومي للسن، نروح بالضبط على السن، نحرك على الاكزيال سكشن ونتلت ذا هول كيرسرز باتجاه الميد روت. نحرك برضو الاذر لاينز. الان احنا بدنا نشوف الكورونال والساجيتال والاكزيال. بالاكزيال بنقدر نعمل سكرول داون carefully as we are taking slices of the tooth, and we can see what is in there. You can see the gouging start appearing. So there is a gouging here, black axis, and possibility of perforation. Going more down, seeing the getaverka, you can see a perforation here. And the mist canal here. So now we could understand why we have pain. We have a perforation with getaverka in and the mist canal. And also we have a C-shaped molar. And that's why the dentist was looking for the third canal. He could not find it and he perforated the tooth. Now we can plan our treatment. The perforation site is at the crystal level, which is the worst place. So we might go for restoring it with glass ionomer. And locate and find all the canals. And let's go for the upper premolar. Now we move to the other tooth, the upper 4. برضو نفس الشيء احنا من alignment بس we cannot tell where is the calcification, how deep we need to go with our drilling. So we go for the oblique slices, same like what we did before. Try to locate the tooth. We go more to the tooth itself. You can see the coronal section now and the sagittal section. Now we are almost in the mid of the tooth, in the center of the tooth. فبنقدر نشوف من الاوcclusal surface how it looks on the axial section. On the axial section, we can see that the caries is deep, but the occlusal surface is almost sound. So that's why it has been missed by the dentist. And the caries is quite deep. It's almost perforating in the cervical level, slightly above the bone. When we scroll more down, we start seeing the evidence of the canal. The canal is calcified in both upper 4 and 5. Now we start seeing the canal in the 5, and we will look for the canal on the 4. I recommended that you use the mouse, guys, to scroll down because it's faster. Now we start seeing the canal here. So how deep we have to drill to find out the canal? In this case, we can align our lines and decide the point, and then go to the ruler, detect the measurements, and measure how deep we have to go. So we have to go between 7 and 8 millimeter until we expect to find the canal. So we further assess the anatomy. We can see that there is two canals on a ribbon shape, and the two canals are in one lumen, so it looks like a ribbon-shaped canal. And we go more further apically, we can see that it turned to two separate canals. So we expect calcification, and then we go for one canal. We have to drill buccal and lingual and prepare as two canals apically. Okay. And this is the post-treatment x-rays. This is the lower 7 where we did the retreatment. We found the third canal, and then we seal the area, the gouging, with the glass ionomer, and we place Teflon on the gingival margin to allow the glass ionomer to set without contamination. For the upper 4, we did the same. We just drill, remove all the caries, find out the canal at the level that we expect, and prepare the tooth and obturate, and then restore the tooth with composite. Second case is a retreatment case where the case initially was seen, then we decided to go for a CBCT. The crown was disassembled, the amalgam was removed, but what was interesting that the cadaver is stopping here and the lesion is on the lateral side. So the initial felt that there is a ledge or that there is a kind of curvature or blockage. We could bypass it by pre-curving the file, but the curvature was quite big. There's a site of resorption here and a lesion, so place calcium hydroxide, and this is, I think, at the time of operation. And this is the CBCT for the case. So we go again with our curved slice. We align our tooth. We can see in the curved slice that there is a curvature on the canal, and the opening of the canal is laterally. But we cannot assess the curvature clearly. We cannot go exactly where to remove the tubercle. So, going again to the oblique slice, you can see the curvature. On the oblique slice, we can go perpendicular to the tooth. So, looking for the tooth on the axial, align the 3 lines or 2 lines to the mid of the tooth. So now we are intersecting the tooth from the middle. We can change the line on the coronal section, on the surgical section, and in the coronal, and we can assess the anatomy clearly from the occlusal down to the apex. So we're scrolling down now. Now this is the cataperca. You can see it here. And we can see where the cataperca stops. And here we can go back again to the sagittal and measure how deep I need to use my retreatment files. So I don't need to insert the retreatment file to the full length. So the cataperca is around 12 to 13 millimeter. I can use the retreatment file up to there and then start my journey of hand file negotiation for the canal until I can reach the full length. You can see also the C-shape configuration for the lower 5 and the location of the canal that is going more buccally and to the lateral. So the opening of the canal is more to the lateral. So this is the second case. For the third case, we have a calcified canal that was referred to me by a prosthodontist, and the patient had no pain at all, but calcification. There was an attempt of an access before. I tried to find the canal, I could not, and then I referred the patient for a small field, high resolution CBCT. You can see now, in this case, we could go again, align our treatment to the tooth. So we measure from this slide is 6 millimeter to the axis. On the oblique slice, we can be more accurate, so we can measure exactly where to the palatal canal. You see that we have to drill with a slight of curvature, so we can reach the canal. And here is where the canal starts, the palatal. So this is the original canal. So go back a little bit. This is our drilling. So this is our drilling here. This is our drilling. And you can see the canal is not yet visible. Now this is the canal. We were drilling this location, and the canal is more of here, more toward the buccal. So we decide where the canal. Also, we verify that there is no lesion on the mesial and distal root, so no need for digging to find the canals, as they are very narrow and very small. And this is a high resolution CBCT, so still we could not see the canals, but they are very, very narrow, and no need for finding out the canals. Only the palatal is patent, so we did plan our treatment that we will do the palatal, and we will not touch the mesials. We're just going to restore the tooth and refer it back to the prosthodontist for the crown, and we will follow up the patient for any further management surgically if there is a failure. Thank you very much. This is for today. This is the post-operation for the case, and I would like to invite you for the 8th Pan Arab Endodontic Conference that going to be held in عمان. بتشرفونا بعمان في فترة 2 ل 4/10. ده مؤتمر البان أرب اندودونتيك كونفرنس، وحيكون في مجموعة من السبيكرز الانترناشونال والعرب اللي موجودين معنا اللي مميزين، واللي حتستمتعوا فيه مواضيع بتهم جميع أطباء الأسنان بالاندو بالذات. AI الاندودونتكس هنحكي عليها، السيرجيكال اندودونتكس، الريزوربشن، ريستوريشن اوف اندودونتيكالي تريتد تيث. حيكون الثيم ان شاء الله يونيفايد برسبكتيفز، وننتظركم باذن الله. وشاكر جدا لحضوركم للمحاضره، وبحب اشكر طلابي اللي دائما لهم مكان بالقلب. وبتقدروا تتواصلوا معي طبعا على الاكونتس على الفيسبوك او على الانستغرام او على اليوتيوب، وسعيد جدا اني اكون معكم. شكرا دكتور مازن على الدعوه الكريمه.